Passive range of motion utilized in the trismus patient can be valuable post-surgical as well as post-treatment when our patient is not able to yet get to an active range of motion. Now, the benefits of a passive range of motion are working towards preventing some limitations within the joint mobility, preventing, hopefully, some of those contractures and addressing the continued length and elasticity of the muscle. We also hope with passive movements to improve and stimulate the proprioceptors, and we want to prepare the muscles for active contraction. So I'm going to show you a few passive movements that I may utilize if my patient is not ready for active stretching yet. Now, I can do passive as externally as the clinician to the patient, okay? And I may utilize a Theraband. Now, selecting the color or the tension of the Theraband specifically depends on the patient and their tolerance, okay? So for right now, I have a light Theraband and I've cut a piece off. And so what I'm going to do is I'm going to place this Theraband and hook it on my patient's bottom dentition. If they do not have bottom dentition, then this is not a choice for you, okay? So I'm going to hook it on my patient's bottom dentition, and I'm going to encourage my patient to open and close against my very light resistance, okay? And I'm not having the patient sustain. I'm just having them move up and down. That's all our goal is. So place it in their mouth, hook it. Okay, that would be considered a passive range of motion. Now in our trismus patient, it may look very tiny and small. So you may only be able to get it between those dentition of maybe 5 to 6 millimeters. And so that's going to look very different for that patient. Now, if I have a patient who is reaching 8 to 9 millimeters, then I'm going to consider moving towards utilizing the device for passive range of motion. And that would look like having my patient pinch the device, place it in the mouth, and allowing the device to open their oral cavity. Pinch, come out. In the mouth, open the oral cavity, okay? So again, we're working here towards joints. We're working towards muscle elasticity, but we're not actively contracting the muscles, okay? Additionally, I would place it in and have the patient bite down. Now, there's no active contraction and hold to engage those muscles to work towards improvement of the muscle fibers and tissues. There, what we're doing is working towards elasticity. So when would I utilize a passive? And this is very specific to your patient. This is driven often post-surgical by the surgeon and guided by our ear, nose, and throat if surgery was involved. This is also considered potentially during treatment if the patient has an active tumor that is being treated that they cannot tolerate active range of motion. And the reason for the trismus, the etiology of the trismus is tumor. It's not radiation associated at that point for that patient. Additionally, trismus could potentially be post-surgical changes. And so our ear, nose, and throat physician may allow us to start with an order on passive movement with the goal of eventually getting to active, okay? So knowing when to utilize passive is essential as a clinician. Passive movements are considered movements in which can either be externally driven by the clinician, but the primary goals of a passive movement are range of motion, elasticity, and addressing mobility of the tissue, okay? We want to continue as much pump and flow, but we are not actively engaging the muscles of mastication to try to improve and bulk that muscle at this point, all right? So I hope that's helpful in clarification. Please feel free to ask me any questions. As I know, as speech pathologists, passive versus active can be very challenging for us, while our physical therapist colleagues sort of rock this world. All right. Thank you.